At this meeting I gave 2 talks which had similar topics, and it's mainly about the fact that the treatment landscape in AML is changing at last after a couple of decades in which we didn't have any change, but there are now major changes happening. And my topic was that we have now several newly approved drugs available for the treatment of AML, but not all of them are best suited for every patient. And my topic was how to select the best treatment for individual patients. I did that partly based on clinical cases, and I was focusing on first-line and intensive treatment. Regarding that topic, we have 3 newly approved drugs in Europe. One of them is midostaurin, a FLT3 inhibitor. The other one is gemtuzumab ozogamicin, that's a conjugated CD33 antibody, and there's a liposomal formulation of cytarabine and daunorubicin that's called CPX351. And those agents should be used in several or different subgroups of AML. Because of that, it becomes more important to classify patients before we start treatment. So we kind of observe 2 paradigm shifts in the treatment of AML or of fit patients. One of them is that we have to abandon the one-fits-all approach. We have to treat different patients differently. And as a result of that, we need to wait until diagnostic results are back before we can start treatment. And that's also a paradigm shift, because in the back of our heads there is this idea that AML is always an emergency, and there are data from the US from around 20 years ago or so showing that in younger patients, if you postpone treatment, it has a negative prognostic effect. However, there are contradictory data, French data from more recent analyses showing that also in younger patients it doesn't really matter whether you wait a couple of days until you start treatment. And because of that, it seems that the potential benefit we have from treatment with newly approved agents in the right patient subgroups is probably higher than kind of a negative effect we might have from waiting until we can start treatment. Obviously, there are situations, clinical situations, in which we cannot wait for treatment, such as neutropenic fever or hyperleukocytosis with leukostasis syndrome. But in all other patients, it seems to be a reasonable approach to wait for genetic results to be back before we start treatment. Beyond genetic results, there is also the presence of myelodysplasias or AML-MRC features, which may direct physicians towards a certain direction.